So welcome everybody to this session. We are really pleased that so many people made it to this parallel session where we will have about 1 hour now to discuss together around the redefinition of hospital leadership around the patient or even with patients. We will get there. And I'm very pleased to see the patient representative being represented very nicely just in the first row here with us. We hope that we can also expand questions to the audience. We prepared some questions for our panelists that I would like to introduce. We are very pleased to have them here. But first of all, I have to inform you that I'm not Idris Gessous, if you didn't remark it yet. I'm very sorry, but he cannot be with us today, so he asked me to take over the moderation, which of course I did with great pleasure with such a great panel. But of course I cannot replace him, but I will do my best to animate a great discussion amongst us all. So we welcome today on our panel, first of all, our patient representative, Juliana Mordant. Welcome. Thank you so much for being with us. Then we have Professor Clara Posfet-Barbe. She's the medical director of the Geneva University Hospital in Switzerland. And now I have to be very attentive to pronounce it right. We also welcome Ethan Hassoun. He's internationally coming from the US, from Los Angeles, from Cedars-Sinai to discuss with us. And last but not least, we have with us the Director General, Robert Mardini, who is also on the panel with us to discuss this important subject of leadership around the patient. Well, to kick off the discussion, I would like to introduce the first question that I would propose we discuss it all together. But maybe we start with you, Robert. Could you share one moment that has been a highlight in leadership toward patient-centered care or leading with the patient that no textbook could ever tell you?
Thank you. That's a great question. Sorry. Thank you, Manuela. That's a great question. And actually, the memory that comes to mind predates my time serving the HUG, and that was when I was serving the International Committee of the Red Cross as an engineer, where part of the job was about rehabilitating hospitals affected by armed conflicts. And I will never forget, after a massive rehabilitation project of the Basra Teaching Hospital in Iraq, where as engineer we were proud to have rehabilitated and put new equipment into the hospital. And during the work, there was a lady still at the hospital, and we were trying to have some conversations together. And this lady shared that she was always afraid from hospitals, doctors, nurses, and yet she was still there. And I asked her if she was happy with the work. She said, yes, of course, but the best part of it is the human connection. The best part of it is this nurse, among many others, who had the courage and leadership to slow down, to discuss with me, to make me feel like I'm the center in the midst of hectic operations in the hospital. And by the way, around the hospital, there was still some fighting happening. But for that very lady, the most important part was her personal fear about what hospitals represents. And I think I learned there that leadership has no ranks. Leadership is about how you connect with people and how you make people feel better. And because at the end of the day, this is what people remember, how you make them feel. And I said to myself that everything we do in hospitals is very important, But what is absolutely central is this very feeling of a patient who can feel better when the human part is done better. Thank you.
Thank you very much. Ethan, can we continue with you?
Well, good morning, everyone. It's a pleasure to be here. I see many faces I'm very familiar with and many that I'm not. So I'm a vascular surgeon. I still practice a little bit. I'm mostly a hospital executive and have been for a while now. A bit removed from the front lines, but I still, really, the greatest moments are that interaction with patients. I think I would spin, like when you ask this question about leadership, I'm gonna extend that from Robert. And rather than give you a story about one individual case, I think what I've learned, I think this is part of those of us who enter middle age and beyond, you get a little bit older and you start visiting doctors and hospitals more often than you want. Whether it's for yourself or, I've been through it all. I've had illnesses, I've been in the ER, scared for my life, and then I've been even once in an ICU. I've carried a parent through their final days of healthcare and until they passed away. So those of you of a certain age, you'd recognize this. And what I've learned through all of this and through my being a physician is that there's real no separation between patients and providers. We're all just people. And I think I even have probably further that advantage or luxury, I suppose, and those of you who are physicians and practicing, and you can recall going through med school and residency, you become the identified person in your family that everyone goes to or friends. And the lines become very blurred. And so for me, honestly, I think that I spin the question differently. I think the most important thing is to realize when we're, whether you like to wear a white coat or a stethoscope or however you do it, at the end of the day, these are just people, and for me, it's a continuity of my life into my care as a professional is one and the same. So I think that is a subtle point, but also it's a very powerful point because, and we'll get into conversations about how organizationally we bring patients into the center of what we do, but I think it helps when individual providers realize that the person in front of you in illness is really just going through a moment in time and there's no labels or differences between us.
Thank you so much. Clara?
So maybe I wanted to share an experience I had maybe 3 years ago. Not that I was not interested in the point of view of the patient. As a pediatrician, we always work with the parents as proxies, and we also sort of interpret each child's point of view through the parents' views. But 3 years ago, we set up a new clinic for complex care at our hospital for children who have more than 3 specialists taking care of them, meaning that they have a lot of consults, they have a lot of people they meet all the time, they have a lot of blood work and everything, and we realized that these children were having too many blood draws, they had too many consults, that they had no one who was really taking everything in charge together. And so we built up this consult with patient partners that are here as well, talking about what would be useful for them. And so we had made a huge list of things that we thought was useful, and we thought of what it could help them and everything, and we went through that list with families, and actually half of them was wrong. It was either not a problem or things were missing that we didn't even think of. And I think that experience really showed to me that we sort of overinterpret sometimes what we think is the need, and the families or the parents or the patients have other needs that we don't identify. First, in a very concrete example, we thought that concentrating all the consults in one morning instead of coming 3 days in a row for one consult would be easier for the families. Because we thought, okay, they have to come to the hospital and everything, and there we can do one blood draw, go back. Actually, certain families really liked that concept, but some didn't like it at all, because they said that their kid cannot stand staying in the hospital for 4 hours, that they cannot take off every week 1/2 morning. It's easier for them to go 1 hour later to work than take the whole morning off. That they are missing school, which is a problem. They're trying to keep that up. So actually what our perception wasn't something that one size fits all and that could work. And therefore the feedback of the patients and of the families had been immense. And I think the way we shaped our consult now works for all of them, because it's really personalized, it's really specific, and they could express their needs. Of course, it also means that you have to always re-question these. And again, that's why I think that patient partners should be involved not only in the creation of a project, but also in the continuous evaluation.
Implementation. Juliana, so you hear here the hospital leaders. What are your thoughts on this?
Well, there could be a lot of examples that all my partners, colleagues who are here could speak about, but I will say that today is a big event for us, like being a part of this incredible event and having a voice here. It's really something reshaping how we design leadership with, for, and through the patient experience. I have a lot of examples. Here I will mostly be a representative of what is happening already in the University Geneva Hospital. And I will say that the first thing is that we have a real partnership. This is not something, this is not symbolism. This is not about having an alibi, a patient alibi. It's really, we have a voice. It is included in a lot of steps, different steps, through training, research, designing new patient journeys, decisions now yet, and of course, representing what we are doing every day. What I have to say also is that you have among here people who are patients, and I'm practically sure that you are patient as well, or maybe you have families and you are caregivers as well, and this is something that is crucial in the way we think and we shape leadership around the patient.
Thank you so much. So what I hear from all the hospital leaders, but also from you, Juliana, is, I mean, that we have to take every person with the needs this person or this family expresses, and the leadership should really recognize the individual situation and humanity in this situation. The big challenges, I mean, I'm training nurses, I'm an academic, and so we have an institute, we train or we educate advanced practice nurses. So we are telling them a lot about leadership and, you know, this individual approach, a needs-based approach and so on. And then they are often catapulted into hospital systems where this is not always, you know, mentored, not always the case in the clinical day-to-day living. So what, as hospital leaders, can we do to, you know, to facilitate such an approach that really puts this individual encounter with patients, with families and clinicians at its heart? And maybe Haytham, I let you reply first, and then the others can maybe react on this if it's okay.
Sure. Yeah, that's a great question, and I think we start getting into the heart of the subject, the meat of the matter, so to speak. You know, the easy answer would be you have to create the culture, because processes will not transform the feeling for the patient. People will just be buzzing around and pressing on the instruments and doing their job. But then when you hear that, and I'm sure you all have this feeling, what does that mean when you create the culture? So I think there's two things I think of at once. One, your hospital, generally speaking, is a reflection of your community. At least the hospitals I've worked at, and I have interacted with countless hospitals around the world in my job. But one thing that resonates for me is how important it is that the leadership has to connect with the community to feel like you're of the community you are in. Even in places where the providers are of an international background, like in the Gulf countries, et cetera, you realize that you have to, as leaders, you have to create opportunities and provide the environment in which you connect with people on a very community-based level. That's going to help with the cultural transformation. On the more tactical side, I could say at Cedars-Sinai, we've been very intentional. We have something we call a patient and family advisory program. And that's almost like a hospital executive committee, believe it or not. And this has sort of subcommittees or different ways we approach patients and bring them into our hospital operational decision making. even have an online where you can be a member and provide online your inputs, and we have up to 35,000 patients online providing these inputs. And in fact, we create committees where they're sitting at the table with executives and directors and things as we make the decisions around processes in the hospitals. And one of the things I think, and we've learned through this, is that they actually are meaningful changes, and they're very important, and things we may not have otherwise thought of or included. So I think this type of intentionality is very, very critical, and I already see this just by the branding of the patients here, and I look forward to hearing more stories from the local environment about this, because I'm sure you're doing much of the same here. Thank you.
We will probably listen to the answers of our other panelists, but then we would also like to open to your questions or comments if you would like to add something. But maybe Clara, I can let you comment or add something.
Yeah, I think building up a culture of patient partnership within the hospital and the governance is super important. I think that the fact that we integrate in almost all projects a patient partner that is on an institutional level, but also in a very local, departmental or smaller level, and we sort of had to force it at first. Not everybody was seeing the use of it, but having to force it at first, and after that the people could really feel the difference, that it brought something that was not just an alibi to have somebody on the panel, but somebody who has this feedback and everything has made a change, not over 1 year, but over several years. But I think now it's really embedded in our hospital. I'm almost also say that this group that is only a small panel of our patient partners are an incredible group, and they are led by somebody who's also in the room here, who could also make them more useful, because one of the little risks that there is with the patient partners is that they start really from their only small experience, which is not small in the scope, but regarding the whole hospital. They have to have this vision that their experience can be expanded to other people's experience. And this group has been amazing in doing so, and have been bringing more and more solutions to problems we had or problems we didn't know we had. And they have been more and more active in this care. You also mentioned the research part, and maybe this is something that is less heard of, but we have a very active patient partner group in research. More and more, again, the funding institution ask for patients to be involved in the research, and that means not only, again, as an alibi, but to formulate the right question, to find the right outcome, and to deliver it in the right way. And they also are ambassadors of the final research questions. So this has been very, very strong and going well as well. Also something that is building up, I think in Switzerland, it's still, I think we are a strong threshold in Geneva, but maybe elsewhere it's not as strong. But I think the fact that they are involved in all the parts of the hospital, meaning the care, the research, and the teaching education, is super important.
Robert, when you came over to the HUG from the International Red Cross, in terms of leadership involving patients and families, what surprised you most there? Or did you see other options to facilitate this culture of patient-centeredness?
Thank you, great question, Manuela. So when coming from the Red Cross, we had a mantra, affected people at the center. And when I started at the hospital 1 year ago, I had the reflex, and I like to say in all the meetings I was sharing, we need to leave a free chair for a patient, the invisible patient, so that whatever we talk about in this room should ultimately make sense for the patient. And I was so happy to discover, actually, the patient partners program that we have, that I think Clara described very accurately, which actually systematizes the culture of feedback and takes it to the next level, which is co-designing, co-engineering, co-creating. And what I really like about this program, and I think it's not just a program, there are names and faces, and they are here, there are many others across the hospital, and there are tomorrow and the day after in the booth here, so please meet them and have conversations with them. It actually puts as a matter of policy that co-creation with patients across everything we do in the hospital is not an afterthought. It's now built in by design, and it makes us a better hospital. Building on what Haitham said earlier, we are very much connected to the community in Geneva. Geneva is a city and canton of 500,000, so there is no individual in the street that has no story about the hospital. And I keep on getting emails from patients, the good and the worse. Hopefully and luckily we have a very high satisfaction rate of 97%, but there is still the 3 or 4% of patients that had a poor experience. And I think we are hungry for this type of feedback to capture what did not work. And very often it's like Clara said, things that we did not integrate in our thinking of what's important for the patients, for their families. And it's a permanent and ongoing improving process. And I think as we go, it's so important to have this vibrant community, by the way, that is invited twice a year to our executive team meeting so that we compare notes, not only patient with a project or a teaching or research project, but also with, at the level of the governance with the executive team to be able to connect in a peer-to-peer way. Thank you.
So we really hear that this involvement of patients and the public in the leadership of an hospital, but also in clinical care, in education, can be a facilitator of this cultural change that we. So Juliana, what I would be curious about to hear you, or maybe also your colleagues, what changed for you when you have been a patient and then you decided to invest time and your resources and your energy in being a patient partner? So what was, why did you do it? But what represented this for you, for your life?
Well, I think it changes quite everything. Being part of, having a voice, and having this ability to be part of this culture, redefining culture around the patient and with the patient. Well, when I first came to the program, which is now existing from almost 10 years, I met a lot of people with vulnerability, with experience, sometimes tough experiences, and we were all here, to create something more meaningful, not in the way of, it's not advocacy, it's really like, okay, how can we build something stronger? How can we connect the dots between maybe a macro management vision and a micro one? And this is what you said, Dr. Postfebar, before. It's like we have this ability to see the details. We have this ability to see, okay, there is a perspective you have to consider. And sometimes it's also helping the doctor, the nurse, knowing what is the struggle for us. But, it's it's an exchange, actually. It's also for the patient and the caregiver is a way to understand what's the meaning of a doctor, what basically are the day look like, and why they do that for. It's like you combine this vision, and then you can go on step by step building this culture. We know it's taking a lot of time, but in 10 years, we've created, thanks to the program leader and to the platform, almost 1,000 implications during with the universal. sorry, hospital university. And we are included also in the changes. We see that. We are already involved in, okay, this is new, look at what you've done. And basically we are recognized. I will say then, in a personal perspective, because I was a caregiver, I started in palliative care. I had the opportunity to grow into my experience, to not be into anger anymore, to understand how can I be a help for the medical system? How can I be a key in that chain and not just a receptacle, as you said? And I'm pretty sure that's for my colleague the same. Like, how can I be a part of it and how can I make my experience valuable?
Well, I would like to open to the audience. Do you have a comment or a question regarding this? What I find personally very interesting, is there a question already? Yeah? Okay. I will hand you over the micro.
Thank you very much. My name is Dr. Ashraf. I'm from Pakistan and I'm leading an organization as a Chief Operating Officer. So my question, it is a very interesting session, I would say. My question is, we talked about the patients, we talked about the leadership. So how can we as a leadership involve the frontline workers like nurses, front desk officers and doctors to empower them to work as a co-leaders for the patient care? This is my question.
So if I understood your question right, you would like to know how could we involve the frontline workers to really make this partnership with patients happening to influence the leadership. Is that right? Okay. Who wants to go first? Ethan?
Well, I think it's a great question, and you know, I think I'm going to default to the culture piece, but we'll try to get intentional. So I think you're getting to the core of how do you treat your providers, and in fact, as I'm sure many of your hospitals, and certainly ours, is focusing more and more now on provider experience as you do patient experience. I think you can't have one without the other. So I think there are many ways through feedback mechanisms, just like we create patient and family advisory, we need to make sure that every single person in the organization feels like they have a voice, that they are heard, and that their actions and their observations are as critical as the CEO on down. So from a principle standpoint, I think that's how I would answer it.
Any comments, addings? Maybe, Robert?
Yeah, I mean, building on what Haitham said, it is so important. And at HUG, we have 13,000 colleagues. It's a very important workforce. The hospital operates across 11 hospital sites, 20 spots where care is provided, and there are 160 different métiers within HUG. And it's so important that everyone feels connected to the DNA of the organization. And it's not just slogans, it's also in the way we ensure that everyone, be him or her part of the medical community, nursing community, or support services, have the right to have great idea, to propose ideas, and there is a funding mechanism that promotes innovations, and whoever within this workforce has a great idea to improve the patient experience or the workforce experience can get this funding and can build this project and be supported for that.
Actually, it's funny. So this panel, I'm here because Idriss was I moderated the session 3 years ago in Dubai for this conference. And I was very impressed by Idriss, and actually the fact that on the panel, which was on patient experience, what I took from it and recall was talking about the importance of provider experience. So we had our own patient experience officer talking about tools and how we get the patient's voice. We had the Apollo medical director talking about how they approach with kindness and sincerity with the patient and what they're known for, this kind of high touch. And then Idris really took it a different angle, and I thought it was very impressive, and this is your question getting to the core, is let's not forget about the providers and their experience is going to be critical to your patient experience.
Yeah. Thank you so much. And maybe because I was originally invited to be on the panel, so now I will quickly change my head. Because what we could do together with the HUG some years ago, we wanted to facilitate this patient involvement in research. And particularly, I'm doing research in oncology nursing, so in oncology. And all the recommendations worldwide, they tell you that you have to train the patients, that they are able to be involved in research, because they have to understand the clinical trial, and they have to understand what a researcher is, and la la la. But what we did then together, also learning from colleagues internationally, we developed education that is given to both researchers and patients together. And this was really interesting because it was the researchers were more enthusiastic often, and I mean some people are involved in this education that are in the room at the moment, but sometimes the researchers are so surprised what they did not understand about patient involvement during this training. So, and it's not about a patient learning how to manage a clinical trial, it's really something different. And it's not only sharing their own experience, but also to think about the population. And this is maybe something we should also take with us for other things, and as Heatham has pronounced it, it's changing this culture, but also thinking about the providers. What can we facilitate to them? And this brings me maybe to a little bit another subject. We are talking a lot on this conference, but worldwide nowadays, about the digital innovations, about all the things that we can develop now also with artificial intelligence, often with the optimism that we can provide better patient-centered care. We had a session this morning where we were discussing this. So I would like to hear your thoughts about, leadership around the patient. What is your perception of the current development of digital possibilities regarding this vision that we would be really leading together with patients? Ethan, you want to start?
Yeah, I'll take a stab at starting it. They have a panel right now in parallel. I think it's on the AI in the hospital, and our chief operating officer actually is on that panel. It would be great here to share this, Brian Croft. I will say that it's critically important. Whether you're like me, I'm a people person, not a tech person. I can barely handle my iPhone, and I'm good there. It doesn't thrill me or fuel my passion as a leader to deal with it, but I also recognize that it's impossible today for us not to use every possible tool to learn in real time. Information is too much out there, and otherwise I'm going to look like a fool in front of my patient if I'm not informed. They must use tools. So of course we have the ChatGPT embedded in our Epic workflows, and we have training progressively the 15,000 employees at Cedars-Sinai how to be very proficient with the use of it within the EMR. Of course, we have a very prominent accelerator program where we bring tech companies into Cedars-Sinai. We promote them, give them the tools to bring things to market. We're proud of ones that we've brought ourselves. One of them called FeedTrail, which we use now at Cedars-Sinai for all our patients to give real-time feedback through the app into the Cedars, into the provider portal. I think I'll take one last thing I want to say about this. Some of the panelists may get into a little more detail, but in principle, we are very much promoting the use of AI responsibly. We have a committee. We were one of the first to create a department of AI in healthcare. People who are on the front lines of researching and studying it, how it applies beyond the operations of the hospital, but actually into the front lines of the care. I think for me on the international side, it's also going to help us connect patients' journey. So I know on the panel most of you are very local and very mindful of your local community, but I run an operation that's quite sizable that's actually focused on patients that are not local community, but they're traveling. So we have a clinic in London, we have hospital, affiliations in Qatar, and other big programs like this have these global places. And those patients become part of your system. And the only way to integrate is to have tools and have efficient tools to be able to create that continuity becoming very adept at the front line to using CRM, Salesforce tools, and that sort of thing. That's kind of newish to hospitals and healthcare workers, where we've mostly been focused of what's right in front of us. But we got to realize that today we are, especially in hospitals like Cedars-Sinai, very much responsible for a global community.
Thank you. Maybe Juliana, do you want to react on this? What is your perception of
AI?
Well, AI, digital tools, but also, I mean, we heard it might be an opportunity to connect to patients that are far away, How do you get into contact directly if you don't use digital tools?
Well, I think we are, a lot among us, involved in digital process thinking, and this is really encouraging. Naturally, around, the old population coming, so this is very interesting. And the discussion that has been put on the table when you start being into the partnership is that you tend to discuss with doctors who said, okay, I want to be more human, I want to be a nurse who is more attentive to the patient, but I don't have that time actually, because the workload, because the amount of administration they have to handle, it is far away from the first mission of a doctor, of the care they can provide. And I'm pretty sure that my colleagues will agree on this. We are completely into redesigning things around the patient through a human perspective, but using AI as the very best solution it can provide to our institutions. And in this panel, we also can involve the fact that we can connect to other institutions. What we are doing here in HUG is really like a model. We can discuss about it, how it's working, how it's really reshaping things, and how digital perspectives are actually really positive on what we're going to create.
Thank you. Maybe I hand over to Clara and then Robert.
So maybe you can share an experience I had recently for one of our research projects where we had focus groups with parents and patients about AI, thinking about, is it something scary? Are you worried about it? What do you think of the perspectives are for the future and everything? What is also interesting is the first time I used ChatGPT is less than 3 years ago, and now I use it every day. So just to show how we couldn't even imagine how AI is going to change our life and how it will change in the next 5 years too. So of course the tools that we're thinking about now will be completely outdated very soon, and the systems will be much better. What was interesting to come back to the focus group was to see that actually the patients were for it. They were not afraid of AI. They thought that it was a plus for them. They were not really worried about where the data went, which was for us more of a worry. And I think that is maybe some education we have to give on why data is important, why we have to have control on it. They also had often a bit of magical view of what AI can do. They didn't know about hallucinations. They didn't know about the sources of the knowledge. But again, this will improve over time, I'm sure, and we'll have much more control of what we can do with it or not. So again, sometimes we sort of imagine what the people think, and then when we ask them, they are less worried about that. We saw this morning an example of a consult that was done, that is recorded and transferred right directly. This is sort of a dream for all physicians. We spend too much time writing out our consults. The fact that it can be exchanged between people and across systems is, of course, something that would gain time, and probably even translations and things like that will be so much easier. But you must also realize that we have no clue what's going to come. And I think we are still waiting for some improvements, knowing that currently when you do a study on do you gain time by this whole system, you don't really gain time. You gain maybe the happiness of not having to type it or just correcting it, but the time in total is not a lot of gain. But again, if we look back to what patients want, for example, if they have an oncological disease and you tell them, okay, you can gain 2 months of life, but you're gonna feel like crap the 2 months, I'm sure most of the people say, I don't want 2 months more, I want 2 good months. And I prefer not to have 2 months where I stay in the hospital and throw up the whole time. So there is some balance to find there.
Can I just, one element, I mean, we were talking about the frontline workers, and this morning we also heard two of the three panelists said fear. As a medical director, what are your thoughts on this? Is there, I mean, from the nursing profession, I know that there are a lot of fears regarding AI and what it could bring, and also regarding what happens with the human-to-human interaction. You know, if we are in this digital era, I don't know if you mentioned the patient's preferences. What do you hear from your colleagues?
I think what you have to think about is what is the purpose of AI and what is the goal that you want behind it. So you shouldn't have AI just to have AI. You shouldn't have just something to make your hospital look good because you use I don't know how many computers to do that. I think the important is why you do it. And if the ultimate goal is to have better care, meaning that you are more available for your patients, that you are more available at the right time for the right purpose, then it's a good goal. Otherwise, it can be, of course, also financial, it can be also administrative, it can be all kinds of different aspects of the hospital care. But if the goal is really clear that it's for the patient in the end, then for me, I have no fear.
I was walking in London yesterday, or I suppose it was Sunday, on the off day, and the North Face, I was walking, so you all know North Face makes the heavy winter gear. They had the best slogan I had seen all year, and I took a picture and sent it to my team. It said, "Don't fear the forecast." And I think that is the theme of 2025. Most of us, let's be honest, the media is an onslaught of AI. Everyone's the onslaught of it. Most of us don't know really what that is beyond ChatGPT. So, but I love that slogan. You guys, it was brilliant.
Thank you for sharing. Robert, what are your thoughts about this?
Well, at HUG, AI stands for augmented intelligence because we are convinced that the future is about how we calibrate and we manage the interplay between artificial intelligence and human intelligence. I mean, AI with all its form, analytical, generative, or agentic, is transforming the way we work, is transforming the way we exercise leadership within our organizations. But I think the key takeaway here is it takes time because there is the data conundrum, and I think most institutions are still grappling with their data, with the poor data policies and governance, and those who settle or solve this problem will be able to leverage the capabilities of AI. And I think AI and humans should learn from each other because the data, bullshit in is bullshit out, so we need to also improve the quality of data so that AI can extract the best. And I think for HUG, as we now adopted our new institutional strategy 2026-2030, there are two main axes. One about how AI will be embraced in the care experience, and there are now great improvements being done in precision oncology, in radiology, and also pushing the boundaries from curative to preventive and anticipating disease before it emerges. And something that was also discussed earlier, which is the challenge we all grapple with, the high level of administrative work that is eating up time that is not dedicated for patients. So AI can definitely minimize all the time that is spent behind a computer in a hospital, and will carve out more space for more empathy, more time with patients to improve the care experience.
Thank you so much. So, but then let's do a forecast. So, no fear, but Heatham, what do you think in 5 years, if we think about leadership, partnering with patients, with the public, where would you like to see Cedars-Sinai stand for? Or what would you like your institution to stand for in terms of leadership with patients?
Well, I think I can't help but I'm constantly thinking in a global context. So we, Cedars-Sinai, to get into more US-centric, and I apologize for that, but as opposed to many of our peer hospitals, we're not a university hospital. We're not born as an academic institution. We were born as a community hospital in West Los Angeles. By geography and by hook and by crook, it is now a dominant top academic medical center in the United States. But we are progressively becoming not just an West LA focused enterprise, but a global one. So our view is to continue to create nodes globally and to continue to create a community that is more globally integrated. And that sounds easy, it's quite difficult. And I've spent most of my career previously at Johns Hopkins trying to understand and learn how to do that from these hospital affiliations that many people don't understand have deep meaning to them, because through that we've learned how to create KPIs and quality standards and benchmarks that transcend boundaries through developing accreditation like the Joint Commission and International and many others, European or otherwise. So I think the future for us is to continue, despite whatever geopolitical or economic headwinds there are, is that we stay the course as healthcare leaders, is to try to get closer to the patients wherever they are and try to create connectivity with providers around the world so that we create systems that are at one, that are unified.
Thank you so much. Juliana, what would be your forecast?
Well, I'm pretty sure that a lot of things are happening already, because it's already here and it's happening fast. And I think we need to completely change the way we see it. Like, if we include the partnership, you understand that the patient now is also able to take care about his own health. It's not only the doctor who is going to say what you have to do. And this is also a leadership aspect we have to acknowledge. This is very important, I think. As well, I'm sure that if we involve good decisions with good, aims, it's like always taking care of quality and safety around the patient. We cannot miss that point. And I'm pretty sure this is like the core value we have to stick on to make good changes with AI. Well, a lot of things can happen, of course, but also a lot of things are already changed, and we see this culture is evolving, and we have a lot to bring also into this leadership through AI. So, you can be afraid, but it's here, so we have to take and deal with it now. It's like patients, they have diseases, they have this vulnerability, and maybe they are the best person to talk to if you are afraid of things, because they are afraid of a lot of things every day.
So you're not fearing the forecast?
I think we have to go on. I think it's like we are creating solutions, and of course there are going to be challenges, but you see, the fact that we are here today is already the demonstration that things are happening. And we have to focus on what is good. We have to see what is already happening around the patient for the quality, the safety, and research, of course, and everything that is going to happen, which is already happening. So, yeah, of course.
Thank you. Clara?
So if I think about hospital leadership in the future, the title says around the patients. I think it will say with the patient. It will not be just around it. It will be really a partnership, and they will be involved not only in the governance, but also in the everyday life. And you mentioned the KPIs or other indicators of success or of good management of the hospital. And I think maybe this is something that is still a bit missing, is the involvement of patients in interpretation and maybe solutions of indicators of the success of the hospital. They are really involved in projects, they are really involved in strategy right now, but maybe not in the follow-up and the propositions regarding the follow-up. But I'm very confident that we are on the right track at the HUG, and I'm very confident that we have partners that are willing to do what we want to go forward to. And when you mentioned about the healthcare workers, how we can get them involved, I think they are already involved and already working with us towards that goal. But it is an effort. It is something that we have to always say, why is this important for you? Why is this useful for your care? And what is your benefit? Because everybody's a little bit egoistic. Everybody wants to have a personal positive outcome for that. But I think we are on the right track and we should continue.
Thank you. I don't know, Robert, is there? Okay, we let Robert comment and then I hand you over the micro, okay?
No, I'll be very short. I think we should be driven by hope, not fear. And if we manage to embrace what technology offers in a principled and ethical way, I'm sure that we will be able, as a community, to address many of the wicked problems and challenges we share, from the aging population to the shortage of healthcare professionals, and carve out more space with the patients and for the patient.
Thank you. So we have 2 questions, if I saw it right. Maybe you first.
Thank you. As well, in the World Congress, I may ask a question on international cooperation. I think we can pretty much be sure that there is consensus on the added value of patient partnership programs for the improvement of the quality and safety of healthcare in a community-oriented perspective. And by the way, Juliana here is a member of the Commission on the Quality and Safety of Healthcare at the HOG. What is being done, though, to try to disseminate worldwide through international cooperation, maybe through dedicated bodies, such patient partnership programs to the benefit of the wider, I would say, humanity and healthcare communities?
Well, I think the short answer is not nearly enough. But I would just say that I think many of our international organizations, which are under onslaught now by many leaders, global leaders, have focused more on public health and type of measures, which is it's still critically important today, but certainly in many parts of the world, and certainly critically important in the last century. I think in more forward thinking, I do think if I had my day with the global presidents and kings and queens of countries, is to focus around sort of modern hospital-based outcomes and experience, and how do we improve those for an individual, not just for a public or system. They're both important, not one over the other.
What would also be very, very, very important as an academic, publish what you're doing. You know, there is the model de Montréal that is cited everywhere at the moment, but I think now in Switzerland we would also be ready to have Swiss models published. And I know that there are some efforts, but I can only encourage you, share your experiences, because so many people will be grateful for that. Yeah. Sorry.
I think it's a great point. Just as you're preparing for the next question, I just want to add the other side of that, and we learned through, obviously, COVID, all of us, is we want to publish so that that information is coming to the public, not just embedded within the academic circles. The challenge with that, though, is keeping it truly evidence-based and not have political or any type of, you know, social. And it's not easy.
Yeah, last. I am Abdullah Blouchi from Emirates Health Services. As a leader, how you measure your either readiness to build this culture or your improvement? Is it by review rates, complaints, clinical outcomes? So how you measure our readiness being as a patient center? The second question is how to buy in people, the newcomers to the organization, the new employees or the new partners who shared our healthcare, because now most of the hospitals outsourcing some clinical service, so it's another culture. So how you buy in these people to be around the patient?
I'll go. I think it's actually a natural extension we talked before, which is that we could do a workshop on the tactics around how do you build the culture that you're talking to. So something I think everyone here who's in hospital management can resonate, you know, employee engagement would be a very simple surrogate. That's just the beginning point to try to understand your staff, your providers, their experience, how they're doing. But we need to drill much deeper at a unit level to get into the specifics. So I think I would answer that specifically by communicating the issues, creating opportunities to measure, and the leadership, the hospital leadership has to provide the resources and the platform to focus on that. So data, evidence, data, and then implementation of those.
Maybe building on what Haitham said, and I think it's a very important question because Gen Z is also redefining the way we engage with our workforce. And I think today the expectations are very different from the colleagues who are now in high ranks in our hospital. They want to have more explicit understanding of the purpose of what they do. They want to engage more with the leadership. It's not, I think, the one-way town halls is something that is revolved. They need more engagement on specific topics, on hot topics, and I think the leadership at various levels of the organization should invest in these moments, because the workforce, the new workforce coming in hospitals is the one who will lead the hospital into the future. And we need to invest time and energy. We need to listen more. We need to adjust the way we communicate. Gen Z are not using LinkedIn to find jobs. They go on Instagram and Twitter, and they put their conditions. So I think we need to have those shifts also translate in our HR policies, in our remuneration packages, and also make explicit the purpose, beyond the key jobs of the hospital.
Okay, unfortunately, we have more questions, but we're running out of time, and I think you're all hungry. But one last statement, maybe really one short sentence, a wrap up. What should people that have been in the audience now, who want to take this vision of a leadership with the patient, with them home, what should they do first when they come home? And Robert, maybe you can start.
I think sharpening their ability to listen and to capture feedback. I think this is the hardest thing, because there is listening, and the real feedback is the hard feedback, and you need to digest it and then translate it into action and improvement.
Thank you. Haytham?
Well, I'm going to stick to my word, which is in our strategic imperative in my group this year, is integration. So integrate everything, integrate your lives to work, integrate your patients from home to hospital. Just try to be aware and integrate, and that's going to help create a seamless platform for patients.
Thank you. Clara?
It's getting harder and harder to be innovative in the response. I think patient partners are patients in the first place, and we have to remember that they are representatives of a big number of other people, and therefore, if you are building up a program, I would encourage you to try to find a diverse group, as diverse as possible, age-wise, socioeconomic, education-wise, just so that you have different voices. I think that leadership with the patient is going to evolve in the future, and for me, it's undeniable that patients, partners will be part of this leadership.
Thank you.
We'll be quick. Consider the fact that the change of a posture can bring the change of the culture.
Well, thank you so much for this wonderful discussion. Thank you to all the panelists, and thank you for having been a wonderful audience. Thank you so much.